I'm going to talk about undernutrition, sarcopenia, and frailty, and try to find if there is a link, or try to convince you if there is a link or not. So in the first 6 slides, I will present some data about the relevance of these 3 conditions. And the first one, as you can see here, is undernutrition. In the left panel, you can see a review of 2010, and you can see clearly how only 14% of older adults that are in hospitals are well-nourished. Only 33% of older adults that are in institutions are well-nourished, and how 38% of community-dwelling older adults are or at risk or malnourished. And in the right panel, you can see non-published data from our acute geriatrics unit in Albacete in Spain in more than 1,000 consecutive inpatients from the years 2018 and 19. And you can see how using the M&A short form or the subjective global assessment instrument, only 20% of my patients were well-nourished. So I have a problem in my hospital. I hope you won't have it. And it's also well known that undernutrition is associated with health adverse outcomes. I present you here 3. In the left panel, you can see from the Singapore longitudinal study of aging how undernutrition is associated with mortality. And we will return further on this figure. And on the right panel, you can see down from our FRADEA study in Albacete, Spain, we demonstrated also that undernutrition is clearly associated with incident disability in basic activities of daily living. And in the upper panel, you can see how those that are at risk of malnutrition with M&A short form lower than 12 have an increased healthcare hospital costs per year. They cost every year 700 euros more than those that have no problems with nutrition. And this was associated, this was adjusted by age, sex, comorbidity, polypharmacy, and also disability. Okay, regarding sarcopenia, we know that actually it's not a condition, it's a disease. It has its own ICD-10 code, number M62.84. And since January of this year, we know that sarcopenia has a framework for diagnosis that was published in Age and Aging by Alfonso Cruz-Gemtoft and other colleagues, and it's very interesting. And we know that also sarcopenia is quite a frequent condition. From the sarcophage study with 534 participants from the community, we know that using the first consensus European working group on sarcopenia in older people criteria, 13.6% were sarcopenic, and using the second and more actual criteria were 7.4%, so it's quite frequent also. And we all know that as sarcopenia progresses, some associated complications appear, like decreased immunity, increased risk of infections, decreased wound healing, increased muscle weakness, pressure ulcers, pneumonia, and of course, death. Regarding our third last condition, frailty, since 2018, we also have a consensus criteria from the European Union Joint Action Advantage that you can look in this. Oops, no, it doesn't work. Okay, in this page of here, okay. And the frailty is defined as a progressive age-related decline in physiological systems that results in decreased reserves of intrinsic capacity, which confers extreme vulnerability to stressors and increases the risk of a range of adverse health outcomes. That's frailty. And we know also from the Advantage joint action that the pooled prevalence of 62 epidemiological studies is of 12% in community-dwelling older adults, but if we include people in institutions or in hospitals, the prevalence can go up to 18%. And we also know from many longitudinal studies and also from a lot of meta-analysis, most of them conducted by Kojima and colleagues, that frailty is associated with health adverse outcomes that are presented here. It increases the probability of mortality 2 times, of disability in basic activities of daily living 2.8 times, falls 1.7, disability in instrumental activities of daily living 3.6 times, and also hospitalization and dementia. And data from our FRADEA study have also demonstrated how the healthcare cost in hospitals of frail older adults is double than those of non-frail ones, from 1,200 euros per year and per patient to almost 2,500 euros per patient and per year. Okay, but the question we have today is that try to answer if undernutrition, sarcopenia, and frailty are related or not, and which type of relationship they have, because it could be of this way, or it could be this other way, that undernutrition produces sarcopenia and frailty, or why not this other way, that when we have undernutrition and sarcopenia, then we can go to frailty. Okay, so let's take a look to this, and not only to the criteria of these 3 conditions and the relationship between them, but also let's try to answer if they have the same physiopathologic pathways, and let's try to see if the treatment is similar for the 3 conditions. Let's begin with the criteria. In this slide, I represent the criteria you all know, I'm sure, that were published in the Journal of Parenteral and Enteral Nutrition in 2019 by Jensen, of undernutrition, I say, and you have it has some phenotypic criteria, 3 phenotypic criteria and 2 etiologic criteria. If you take a look more closely, the first phenotypic criteria, weight loss, is the same criteria that one of the 5 criteria that Linda Fried stated for frailty. So 1 criteria is shared by undernutrition and frailty. And the third phenotypic criteria is reduced muscle mass. And this is the same criteria that uses sarcopenia. So also undernutrition and sarcopenia share 1 criteria. And if you take a look at the etiologic criteria, 1 is inflammation. And as we will see later on, and also Matteo has explained, inflammation is the main pathway leading to frailty and sarcopenia also. This was also clearly stated in this paper that was published in 2017 by Sanchez Rodriguez. In this study, the authors included 95 participants with an age older than 70 and that were at risk of malnutrition with an MNA short form lower than 12. And they wanted to know if they fulfill the criteria of all the nutrition disorder types that were stated by Espen in 2015. And as you can see here, most of them were frail, 94, 44 had sarcopenia, and 19 had undernutrition. So we can clearly see that although they are close related, they are also different conditions. And which type of relationship they have? Okay, first of all, let's take a look to the relationship between undernutrition and sarcopenia. It's well known that when the nutritional status is better, we have a higher muscle mass. And it's also well known that when we have a better nutritional status, we have more muscle strength. So there's a linear and clear relationship. What about sarcopenia and frailty? In this study that was conducted by Franjo, that is a friend of mine in Toledo, in the Toledo study of healthy aging, one of the biggest in all Europe, they tried to know how many frail participants in this study were sarcopenic and how many sarcopenic were frail. And we have the proportions here. You can see how 82% of sarcopenic participants were frail, but how 40% of frail participants had sarcopenia. So the conclusions of the authors are that frailty and sarcopenia are related conditions but different, and that sarcopenia is not a useful clinical biomarker of frailty, but its absence might be useful to exclude this condition. What about the association between undernutrition and frailty? Okay, I will give you, for this association, 4 clues. The first one is regarding prevalence. You can see here data in green from the Singapore longitudinal aging study in more than 6,000 participants. And you can see how 26.5% of participants were malnourished, were frail, but more important, 64.2% were pre-frail, then in 2 years will become frail. And the prevalence of malnutrition among frail participants was 16%. And in the same year, meta-analysis was published in 10 studies with almost 6,000 community-dwelling older adults. And they stated that 68% of malnourished participants were frail, and that 8.4% of frail participants were malnourished. So again, they are related, but they are not the same. We also know from the Nutrition and Health Survey in Taiwan, in almost 1,000 participants, that there are some diets that are associated with incident frailty. You can see here how those people who ate fresh fruit, nuts, seeds, tea, vegetables, whole grains, or shellfish had less incident frailty than those that ate fried food, processed meat, snacks, sweetened beverages, and red meat that had a higher incidence of frailty. So we know what we must eat to be less frail. And if you can make mind of what I said in my first slide, I presented this figure that presents the relationship between undernutrition, frailty, and mortality from the Singapore longitudinal aging study. You can see how frail, in non-frail participants, robust ones that are the upper 2 lines, the orange line are those who are malnourished, and this one, the black one, they are also well-nourished. And you can see how those that are malnourished have a higher mortality. But when we take only participants that are pre-frail or frail, that are the blue lines and the gray line, you can see clearly how they are separated. So participants that are frail or pre-frail and present undernutrition, the risk of frailty is much higher. So it seems that they have a synergistic effect. And the last clue I'm going to give you comes from our recent paper published in 2019 in January in JAMDA, when we presented the new functional classification that tries to explain all the functional independence range from the highest to the lowest in 8 independent categories, from the most robust, the first category, to the severe impairment in basic activities of daily living, the 8th category. And using this new functional classification, we wanted to know which was the scoring of the MNA short form. And as you can clearly see, as we become more frail or more disabled, the scorings in the MNA short form go down. And this has a statistical significance just in the 5th category, that is the category for frail older adults. So it seems that they are also associated. And the same happens when we measure a biological marker like cholesterol. You can see how cholesterol levels go down as we become frail or disabled, but this is mainly of special interest in frail and disabled older adults, not in robust ones or in pre-frail ones. Let's take a look at the physiopathology of these 3 conditions. In this very, very busy slide, I represent the main 5 pathways that explain the functional continuum I told you before, from robustness to death. And you can clearly see how there are 5 main pathways. The first one is the genetic susceptibility that accounts for a 25% that explains frailty. Another one is are the epigenetic changes that lead to an accelerated aging. The other one is inflammaging, the core one, that all the arrows go to inflammaging. And then we have also undernutrition and sarcopenia. And you can see in green color many factors that are related with nutritional status, like changes in hormones, mainly orexigenic hormones. You can see microbiota changes. You can see anorexia of aging, lower increase of calorie and proteins, alterations in taste, smell, palatability, digestive mobility. So there are many nutritional factors that affect frailty. And also, there are many factors that are in orange color. Lower protein muscle synthesis, lower strength and potency, lower gait speed, and many changes that happen with the muscle during aging. So it seems that physiologically all of them are interconnected. And this was very well resumed in this paper from Angulo in 2016. You can see how in a population that has the 9 hallmarks of aging that previously explained as Mateo, the main factors that affect this population are sedentary lifestyle, drugs, nutrition, and chronic diseases that, with aging, go through inflammation to produce cell response to stress pathways that lead to skeletal muscle physiology and phenotypic manifestations like sarcopenia and frailty. So it seems that from a physiological way, they are also well related. What about treatment? And I will finish with this. Okay. With sarcopenia treatment, we know that protein supplementation increase in the left panel lean body mass, and in the right panel you can see how this protein supplementation decrease fat mass. And also, when we apply exercise to these nutritional interventions, there's a synergistic effect, and you can see how in the study of Rondanelli in 2016, this intervention of proteins and exercise increased fat-free mass, the relative skeletal muscle mass, hand grip, strength, activities of daily living, DMNA, insulin-like growth factor, and decreased the C-reactive protein, so inflammaging. Regarding frailty, we have very, very recent evidence from 2019 of the results of the mid-frail study. It's a study conducted all across Europe in 964 participants older than 70 years old with type 2 diabetes mellitus, and they had an intervention based on exercise, nutrition, and an education program. And you can see in the left panel how participants in the intervention group, that are the blue circles, increased the SPPP, that is one of the most important tools for measuring physical function, compared to the red dots that are those from control group. And this intervention was cost effective because the authors also analyzed the total direct health costs, and the cost of the intervention was lower than that of the usual care, mainly because they had less hospitalizations. This has been clearly also summarized in this systematic review and meta-regression analysis of 19 randomized clinical trials that has been published very recently in Nutrients in 2019. And you can see how protein supplementation plus exercise increases lean body mass, increases appendicular lean mass, increases hand grip strength and leg strength, and probably more important, increases walk capability. That is what is more important for our older adults. I will briefly present some data of a study that we conducted and we published 4 years ago in JAMDA, that is the activeness study. It was a study aimed at analyzing the effects of an oral nutritional supplementation plus physical exercise in very, very frail older adults in institutions, in centers in Spain, and we wanted to analyze if there was a change in the physical function, nutritional status, and quality of life. And what we could see, the main results of the study are that at least half of the population we included improved 1 point in the SPPP, that is the minimal clinical significant improvement. And also 1/3 of our population had an improvement in the LLFDI, that is a questionnaire of physical function. And this was true at 6 weeks and also at 12 weeks after the intervention. We had a very good adherence to intervention. You can see here how in this study 93% of our population had a good adherence to the physical exercise plan, and more than 80% of our participants had at least an adherence more than 60% to the oral nutritional supplementation. So after all the things I have told here, I would like to ask you if you think that is it ethical not to prescribe exercise and nutrition for frail or sarcopenic older adults? Because as the authors of this paper, I am absolutely sure that it's not ethical. And if we make a screening of these conditions, we must treat them. We have some aids. For instance, there are some guides that can help clinicians to prescribe exercise and nutritional supplementation or interventions in these frail or sarcopenic populations. I present here one that is Air Plus Activa. You have it in your leaflets, in your bag. And with this intervention, you have an educational program that can help you to increase the adherence of your patients to oral nutritional supplementations, and also tells you which must be the minimum effective dose for physical exercise. Although I have presented you many data about nutrition and exercise, there can be also other interventions that could be of help. You can see how interventions in palatability, oral health, dysphagia, communication, social approach services, depression, treatment of diseases, drug controls, technologies can help us in the fight against undernutrition, frailty, and sarcopenia. And I would like to share with you my thoughts about the link between these three conditions. I think that undernutrition is one of the main pathways leading to frailty and sarcopenia, and probably sarcopenia is part of frailty, although sometimes it's a different entity that can lead to frailty. That all of three conditions share some physiopathologic framework, and that all of them can be treated with nutrition and exercise. We do this in Albacete, in Spain. We screen systematically for frailty in our patients, and if they are frail, we screen for sarcopenia, and we make exercise interventions, and we make also some nutritional interventions. And the results are very good. So, which are my conclusions? I think there is clear evidence that undernutrition, frailty, and sarcopenia are different but close related conditions associated with adverse health outcomes in older adults, that they should be routinely assessed when you see old patients with validated measures in this population, that they share common physiopathologic pathways, and the most important one is the low-grade chronic inflammation or inflammaging, and body composition plays also an important role. And multi-component exercise programs plus nutritional interventions with protein intake, oral supplementation, and vitamin D have demonstrated benefits for these three conditions. So please, let's begin implementing. Thank you very much.